Hi, good afternoon, everyone. My name is Courtney Carta, Chief of Hospital Quality Initiatives at the Maryland Healthcare Commission. So thank you for joining us today to hear more about the upcoming audit that we're planning for. I do have a short presentation with some background information, but we will leave the majority of the time today for discussion and dialogue. So as you heard, we are recording this presentation, so we'll send the recording and the slides out after the meeting. So you can feel free to refer back to this or pass it on to your colleagues if needed, if they were not able to join today. So I would like to introduce Teresa Lee. She is the director of the Center for Quality Measurement and Reporting here at MHCC. And she is going to give a few introductory remarks before we get into the presentation. So Teresa, I will turn it over to you.
Okay, thank you, Courtney. And thank you everyone for participating in this webinar. As many of you know, we have conducted data quality audits of our NHSN data, the HAI data that's submitted through NHSN. And we've also conducted audits of data submitted through and to the HSCRC and the case mix data. And what we'd like to do this time is to start this HAI audit with focusing on the data that is submitted to HSCRC through the case mix data. And I think it's real important to make sure that you all understand that we recognize that the definitions for reporting CLABSIs and other HAI information within the case mix data, those definitions are a little different than the definitions in the NHSN data. But as I said, for this particular audit, we will focus on the HSCRC data using the HEMA ICD-10 definitions, focusing on present on admission information for the CLABSI to make sure that if there's an increase in CLABSI, that it is substantiated by the data. If there are data quality issues, that we can all learn from what those concerns or limitations or issues are, and that we'll reach out individually to facilities to address those concerns. But overall, this is really an audit, as the audits have been in the past, to better understand and assess the quality of the information and the data used to support our public reporting at MHCC. And it also supports the work of the HSCRC, their quality-based reimbursement program, and other programs that support the hospital rate setting system in Maryland. So I don't have much more to say than that, but this is definitely an informational webinar, as Courtney mentioned, and we are really looking for any questions that you might have, because we would like to make sure that everyone is on the same page with what we're doing and that there's clarity and this can be informative and useful to everyone. And that's really all I have to say, and I will turn it over to Courtney.
All right, thanks, Teresa. So
could I just say one more thing?
Oh, sure. Now
that Lavon has muted everyone, please remember, we want your questions, we want your comments. So I guess you can use the chat to make sure that occurs, but Courtney, you can speak to that.
Yeah, you can use the chat if you have questions that pop up while I'm presenting. Admittedly, I'm not great at monitoring the chat box and trying to present and work the slides. So I will get to the chat box questions probably after the slides. And then maybe after that, you can unmute yourselves if you have questions. Okay, so this first slide here, this is just sort of a plug, but I always like to just send a reminder or a refresher of the reporting requirements at MHCC. They do generally align with CMS requirements, with the addition of 3 surgical site infections listed there at the bottom, which are CABG, hip, and knee. And as Teresa mentioned, we have conducted audits in the past. You can see we were on a roll there for a while, but we've looked at all different types of infections, and we've used a variety of different methods, kind of depending on the infection type. We've looked at NHSN data, we've looked at denominators, we've looked at lab data, and we've conducted on-site visits. It has been several years since our last audit. So this year, we're planning to focus on CLABSIs. We'll be looking at that present on admission indicator. And we're also going to be doing some comparisons of pre and post COVID infection rates, which I'll talk about in a little more detail in a few slides. So I know I'm preaching to the choir here. Of course, we know that COVID has had an impact on HAIs over the past few years. We're starting to see a lot more data, a lot more research coming out. And it's clear that CLABSI infections have been particularly concerning at both the state and the national level. So I just put some headlines here. You've probably read these articles about the impact of COVID and how it's affected HAI prevention and efforts over the past few years. We do recognize that hospitals have gone through so many challenges these past few years, but I did just want to give a quick snapshot of what the CLABSI data looks like, both for Maryland and nationally. So this does come from NHSN and the CDC National HAI Progress Reports. Before I describe this chart, just quickly want to note that this 2020 column only includes 6 months of data because of the reporting exception. So this is not a real trend, but I did just want to display the data for your reference. So when we look at the CLABSI data, the bars here represent SIRs. The gray line represents the infection count in Maryland, and the blue line represents the number of device days. So if we, if we go back to these bars, if we look at 2017 through 2019, Maryland here is shown in yellow and the nation is shown in red. There's kind of a nice decrease in SIRs for both Maryland and the nation. So performance was doing pretty good. If I skip 2020 here, because it's not a full year, and I move over to 2021, you can see the SIRs have both increased for Maryland and the country. So we went from an SIR of 0.7 to 1.06. I also want to point out this is kind of, please remember to mute your lines. So I want to point out the actual infection count as well. So in 2019, we had 211 CLABSI infections throughout the state. In 2021, we had 336. So that is a 72% increase. And again, I want to point out that you know, these increases, it's not just a Maryland specific issue. We have seen similar results in the nation as well. Though that SIR here in the nation is 0.92, so it is still below that 1.0 baseline. So Teresa described the purpose of the audit a little bit in her introduction, but again, I just want to reiterate that this is a quality improvement activity. This is not a punitive process. We are just hoping to get a better sense of what's occurring at the state level, while also providing some constructive feedback for your facility. So we will be looking at the accuracy of the present on admission indicator. Results from past audits have shown that this has not always been coded properly or at all. And if the audit identifies hospitals with higher CLABSI rates, we will review that data quality closely and work with hospitals on a corrective action plan. And as I mentioned, we are also looking at pre and post COVID CLABSI infection rates compared to kind of what was occurring during the height of the pandemic. So we have contracted with Advanta Government Services to perform the audit. Erica Watkins is the contact who we will be working with directly. So you will be hearing from Erica in the future. Unfortunately, she was not able to make it today. So we will walk through the methodology. If there are more specific questions that we can't answer today, we will absolutely get back to you. And we can send out a list of questions to the group if that would be helpful for more clarity. But so just to get started, AGS will randomly select 400 inpatient HSCRC records where the principal or secondary diagnosis match any of the CLABSI diagnosis codes listed there on the slide. And we will be looking at data from 3 different time periods. So we're considering that pre-COVID time period, which is calendar year 2019. And then we're considering the COVID time period of January 1, 2020 through June 30th, 2021. And then the post-COVID time period, or that flattening of the curve, we're considering July 1 through December 31st of 2021. So once those medical records are identified, the auditors will conduct a comprehensive medical record review, and they'll use a standardized auditing tool, and they'll also be reviewing coding summaries. So all findings will be documented. You'll have written explanations and justifications. And so when we ask for the records, I've listed the requirements here. AGS will reach out separately. And when you submit the information to AGS, we are requesting the complete medical record, the associated coding summaries, and the UB04 bills. The records must also include the patient account number, the medical record number, the patient date of birth, and dates of service. So again, you'll get these slides, and Erica will give you all of this information. You don't have to memorize this, but this is just kind of a good high-level overview of the types of information that we do need. And again, once the audit is complete, you'll receive a written summary of the findings, and we'll host another presentation like this to go over the data quality results, including any patterns or trends that we find. And again, we hope this is a collaborative process and an informational effort. It is not to penalize anyone, but we do think that this is a really important initiative. So our timeline or for next steps, we know that we are coming up on the holidays. People are going to be in and out trying to use their leave. So we are going to be working behind the scenes to come up with schedules for record submissions. We'll be doing some coordination with the auditing team. So there are a lot of moving parts, but we hope that over the next few weeks, you can discuss this information internally with your team. You know, if you need to get your health information management teams or your record teams involved, please feel free to send them this information or the recording. And Erica will be reaching out separately, likely in January, with more information about which records to submit and how to submit that information to us securely. And I also wanted to mention, please make sure we do have the most appropriate points of contact. I started with my primary IP contact list, which I'll continue to use. But if there are people that need to be added, please just let me know. And I also want to reiterate that we are flexible. We're willing to work with hospitals to make sure that this is as smooth of a process as possible. So if our timelines are not quite working for you, just let us know. If your health system, if you want to take a more systems-wide approach instead of individual hospitals, that's fine too. Just let us know and we'll work to see how we can accommodate that. So I told you it would be short and sweet. I've included my contact information along with Erica's contact information. But with that, we are happy to open up the floor for questions. And let me just check the chat box. I don't see anything in the chat box.
Hi, Courtney. Hi, Courtney. This is Avi.
Hi, Abby.
My first question is, are you going to validate MHSN data or are you going to validate the HSCRC data?
No, we're not looking at NHSN data this time. We're just looking at the HSCRC data.
Okay. So we are basically like, based on the criteria that we are going to provide, we need to work with the case mix teams to submit the format of the data that you guys need, right? So nothing is coming from the infection control world.
Correct.
Okay, wonderful. That's great. Thank you so much.
But if I could add, just so you know, once we do move through this audit with the results from the case mix data, we may be looking at the NHSN data to compare it with those findings. So but that doesn't require anything on your part. It's just another way of making sure, for example, the NHSN data medical record number should be consistent with the medical record number submitted to HSCRC. The reason why we didn't require, when we implemented the NHSN requirements, we didn't require race, ethnicity, and other information is because our plan was to get it from the HSCRC file. So we still look at both data sets just to kind of use it as another quality check, if you will. So for example, if we can't find certain records in the NHSN system using the medical record number that we find on the HSCRC file, we may ask you about that. So it's just, pursuing that kind of information, but correct, you do need your AHIMA people to focus on coding and other information in the case mix file.
I'm glad you mentioned, you mentioned that, Teresa. So for our entities, each entity have their own MRN that we submit right now. So I think when we provide the data, I'll make sure to include the matching MRN that you guys could use to match it with the NHSN. And
that would be, that would be great.
And as always, we are taking the systems approach. So all 4 Maryland hospitals, I'll be submitting the data to you guys.
I think several years ago, we did a comparison of the HSCRC file, medical record number, date of birth, a couple other elements with what's in the NHSN file.
Got it.
And there were some issues there that we know will need to be addressed, but there's so many things, as you all know, that everybody moves to whatever that most pressing need is, that we haven't gone back to that activity in a while.
Right.
So there is a question in the chat box. Will you be on site or can the records be transmitted electronically? They can be submitted electronically. I don't believe this is on site. Is that correct, Teresa?
That's correct. Oh yeah,
Okay.
that's correct.
Yep. And just want to reiterate the submission process is very secure. We meet all the state guidelines and criteria. So if you have any questions about that, or if your teams have any questions, let us know and we can provide more information about the site that we use.
And that's a good point, Courtney. Historically, the AHIMA, the HIT staff or the HIM staff at the hospital, they would work to submit the measure data through our portal. So many of them are familiar with submitting data through the portal, the MHCC portal. So this should be something that should be pretty fairly easy to transition through with the existing staff at the hospitals.
Okay, there is another question. Yes, the slides will be available. The recording will also be available. So I will send this in a follow-up email. And again, feel free to send it to your colleagues. And I'm also going to be posting this on the Maryland Quality Reporting website on our private side under the Healthcare Associated Infection section. So I'll send a link to that as well, so you can bookmark it.
So this is Kelly from MedStar Harbor Hospital. So I remember from in the past the different audits that were done that involved coding and our NHSN definitions. So is this basically trying to determine whether we are underreporting or overreporting? Is coding CLABSIs appropriately, and then are we identifying them appropriately along with them to align? Is that what the end goal is?
No, we don't expect them to necessarily align because the definitions for each of the data sources are different. Coding a CLABSI in your case mix data may be very different than the definitions that you use to define whether or not it's a CLABSI in NHSN. Those are surveillance definitions. So we know they will be different, but there will be some commonality, if you will. And because there is, that allows us to look at similar cases, for example, medical record number, those other things that I mentioned, we'll be able to kind of cross the two data sets to do that. So on the case mix, on the NHSN data, the cases that we identify in the HSCRC data, we can also append charges. So if we wanted to look at how costly these CLABSIs are, that becomes another possible analysis going forward. But the goal is to make sure that we're capturing the ICD-10 coding in the HSCRC file, so that when we do these analyses or we put anything on the website, we can also say we've validated this information. We've gone back to look at the data. We've interacted with hospitals if we found discrepancies, that sort of thing. But it really is to better understand the data and to confirm the quality and the completeness of the information. And also to add to our understanding of maybe there's some other things that we need to be aware of as we move forward with reporting or, with reporting information to the public, that kind of thing. So I would consider this more as a quality review and an educational webinar, because I think, as Courtney said, this is not a punitive, it's not punitive in intent, it's more educational. So if we're finding that there is something that's being done incorrectly, it may be a gray area where facilities are doing things differently because there is no one standard. And we have historically found in those cases, we could say for the purposes of reporting in Maryland, you should do, this particular thing, not to be inconsistent with any other standardized, national standardized guidelines, but just to make it a little more consistent across facilities. I mean, if that helps, but it really is to just look at the quality and to inform and educate.
Yes, that helps. Thank you.
Mhm.
Hey, Courtney, this is Kirk Husledge from LifeBridge Health. I know you guys are still working on the timeline. Do you anticipate those record requests are going to go out before Christmas, or do you think we're going to get into January before we're getting those data requests?
So our timeline is still a little bit fluid, but I would say probably January.
Okay.
I think it'll be difficult trying to do it in December.
Okay, that's comforting to know. Thank you.
Oh, I was about to ask, is that comforting, or would you like to be on the first list in December?
No, not stepping forward to volunteer, but I don't have to. But no, it's easier. It's certainly much easier to have it, to plan for it in January. It's easier to coordinate efforts. So.
Yeah.
So there is a question in the chat to confirm for the audit, Erica will be sending a list of medical record numbers for us to reference and send the info. Yes. So just be prepared for an email from Erica. I would also recommend putting her email address in your address book. It is a very long email address. You can see it here on the slide, and sometimes it goes to spam. And if you haven't heard from her yet, you might be later on the list, or if you want to make sure you didn't miss an email, just let me know. But yes, just expect an email from Erica for the medical record numbers. And then Julia, your hand is raised.
Hi, thank you guys. This is super helpful. It makes me feel much more comfort moving forward, just having the questions answered. Just really quickly, I think you said it in a previous slide, but will there be an opportunity to kind of tweak the points of contact, since initially we kind of thought IP would be owning this and we weren't sure how much IP work and data would be involved, but it sounds like it's coding. And so is there room to kind of take them out of the middle?
Yep, absolutely. So Julia, you're with MedStar?
Yes.
Okay. Yeah, if you want to just let me know separately who the contacts are and if you want me to take the IPs off the list. But we do think they're going to be an important partner.
Yeah, let's stay on for now, and then we can think about hopefully having a centralized approach for it.
Absolutely.
And Courtney, we could get the case mix contact list from HSCRC and send the webinar, the webinar to that list as well. And then going forward, we can have 2 contacts per hospital. One would be the IP and the other would be the HIM contact. But I think what we're used to working on for our audits are the infection preventionist contacts. And we just think no matter what, you guys should be involved, because even if we weren't talking directly to you and you heard of an audit that is looking at HAI data, then that's still going to cause some concern. So we could probably send it to the case mix liaison list that the HSCRC maintains so that they all know what's going on too.
Yeah, I think
But make
that's
sure
great.
that everything, both contacts are on.
Yep, so we'll just try to make sure that we have all the appropriate people looped in, so that, we want to get the word out. We don't want to have tight control over who gets to see it. So yeah, we're definitely happy to send it out to as many people as we can. Any other questions? All right, I don't see any more questions in the chat. But again, as you share this information and talk with your teams about it, and as questions arise, please don't hesitate to contact me. You have my email address, and we are happy to answer any questions that come up, because we want this to be a smooth and really informational project. So we're looking forward to collaborating with all of you, and we will be in touch.
And last comment, Courtney, if I could.
Sure.
So the MHCC is, of course, sponsoring this audit, and AGS is our contractor. Erica is your contact with AGS, but all correspondence should also include Courtney, because she is the overall, she's managing this process overall, but Erica will have the specifics, and even Erica will include Courtney in the correspondence. So we'll keep all of communication rolling in a comprehensive way.
All right, well, thank you all for joining us today. We'll get this information downloaded and sent out in an email a little later on today. All right, have a great day, everyone. Thank you.
Thanks,
Thank
Courtney.
you.